All right. Jeff, it does look like it's working. Like I think I can control the screen, and I don't know, Rach, can you do the same? You're on mute.
I don't think so.
Okay, well then I'll just drive and you tell me when when we change.
Okay,
I'm going
great.
to take control for just a second so I can let people in the room.
Okay.
Of course, please do.
Hi, Mo and Rachel.
Hey,
Hey.
How are you?
doing well. How about yourself?
Well, the allergies started today. You know, I have everything. I think I must have spent a lot of time outside over the weekend. So,
For sure. I was going to say it's only hitting you now. I think I've had like weekly allergy headaches for like 2 or 3 weeks now.
yeah, maybe anything.
You were just immune to it.
I don't know. And it's or who knows? Listen.
So give people maybe another minute or two before we get going.
Yeah, that seems great. People are still joining.
Right. Oops. Can you guys hear me okay? Yeah, okay. All right, well, let's get going, everyone. Thank you all for joining. I really appreciate it. So it gives me great pleasure to chat with all of you, and thanks to the Georgia Center for Diabetes Translation Research for the opportunity. We're going to really talk mostly about the core that we have and how potentially through databases and implementation science methods, we could illustrate ideas of how many of you can get engaged with our core, how you can look to doing fantastic innovative diabetes research, and potentially also some implementation science to improve prevention and care. So our agenda for today is as follows. Hoping this works. Yep. Just to introduce ourselves, and then we'll talk a little bit about databases, a little bit about implementation science methods, and then hopefully share a few slides with you specifically about the opportunities at our core, which is called the Design and Evaluation for Equity core. So I'll start introducing myself, and then I'll ask my co-presenter to also introduce herself. My name is Mohammed Ali. I think I know many of you on the call. I'm on the faculty at the Rollins School of Public Health and in the School of Medicine. And I do a combination of epidemiology, health services, and implementation science research related to diabetes. Rachel?
Great. Hey, everyone, and thank you. So I am a professor in the Department of Surgery, but also jointly appointed in the School of Public Health Epidemiology. I'm an epidemiologist by training, and I direct our Health Services Research Center in the School of Medicine's Department of Medicine and Department of Surgery, and also do work in the area of implementation science and health equity. So now I'll go ahead and turn it back to you, Mo.
Thanks. So, the idea of sharing what the databases can do, hopefully gets you excited about some of the examples out there. And we will present an array of different data sets in the next 15 or 20 slides that really are focused, as you will see, on identifying gaps and potentially identifying health inequities. And hopefully what it should illustrate for you, and certainly has worked out in my career, and I'm pretty sure it has in Rachel's career also, is that it's really through identifying the gaps that you develop a rationale for some sort of intervention. And potentially through identifying the gaps, also through identifying the health inequities, you identify high-risk target populations and potentially even targets for intervention and implementation strategies that may work to address them. So bear with me while you'll see this plethora of data. And we'll try to focus again on every slide on the database itself. And we'll share with you how we have plans to make some of these available through a compendium of data sets through our website. So to get us going, here's the first one of many. And this is the use of the National Health and Nutrition Examination Surveys. Here in the CDC's recent report, they've used 2001 through 2020, but you can actually go back to late 1988 for very good, high quality data, and perhaps even actually beyond that. But if you want contemporary data, these are terrific. These are national surveys where they do sampling so that it is nationally representative of the US population. They are freely available on CDC's website. And they, in addition to collecting survey data, they collect biospecimens on everybody. They collect anthropometric measures on everybody. And as you can see here, the CDC report does a really great job where they merge data over 4-year periods. They're released in 2-year cycles. And for precision, the CDC recommends strongly that you use 4-year data increments. And you'll see here the rise in diabetes over the last couple of decades. And before that, it was even steeper. And you'll notice now that approximately 11% of the population in total has diabetes. 28.7 million of those are diagnosed. So it's about 76% that are diagnosed. A good healthy 24% still remain undiagnosed. And that number is staying pretty flat, as you'll see at the bottom of your screen here, the 8.6 million. So you can also use those same data to then stratify by race ethnicity. And you'll see here, this is standard age-adjusted prevalence. And you'll notice that they've done this both for men and women, and they've done it for different race ethnic groups. In particular, you will probably notice that every group other than non-Hispanic whites has a higher prevalence. And it tends to be pretty even by gender, as it were, except potentially in non-Hispanic Asians, but even then it's sort of a non-significant difference. Next slide. There we go. You could then use other nationally representative data, which are again available on CDC's website, called the Behavioral Risk Factor Surveillance System, which are all self-reported data. They do phone surveys around the country. These are data again from the CDC national report recently, using the 2004 to the 2019 data. What's particularly helpful about these, as you'll notice, is that you can go down to the county level and you can get county level estimates of diabetes, self-reported diabetes risk factor behaviors, and self-reported management behaviors. So you can get a whole lot of information out of it. It also has a number of health equity variables that include race, ethnicity, and several social determinants of health. Here are data from the National Health Interview Survey, another survey that is very large, almost 100,000 people surveyed every year. In this case, this is again purely self-report. You'll see that what we did in this particular case is that we used NHIS a few years ago just to give a cross-section in 2017 of preventive behaviors in diabetes. They have a new module as of 2016-17 that focuses on people with prediabetes who are at highest risk of diabetes. And you can find out essentially what they're doing to engage or not engage in preventive behaviors. So if you look at these cascade or continuum of prevention diagrams that we generated, if you first look at the left side, you'll notice of those people who know they have diagnosed prediabetes, and that's about 14.6 million people. Back then, the denominator was about 70 to 80 million in total. So this was only about 15 to 18% of the people with prediabetes who actually know that they have prediabetes. You'll notice this drop off in those receiving any advice or referrals to weight loss programs, any of those getting physical activity advice, any of those getting dietary advice. And then here are the referrals: weight loss prevention, weight loss programs, or DPP programs, specifically National Diabetes Prevention Program designated programs around the country. You'll see this very steep drop off, showing you really that referrals may be a critical component in potentially improving engagement in diabetes prevention programs. And you'll notice here that the lightly blue shaded is the engaged, and the ones that are white are not engaged. So even if you got advice, did you actually engage in the behavior, like physical activity, for example, where my cursor is now? You'll notice that it's about 2/3 of those that actually got the advice that engaged in something like that. If you believe that the diagnosed proportion is too small, and that potentially a wider group of people out there who have diabetes risk factors should be engaging in these, you could use a different definition. And so we use the ADA risk score for this. And so if you look at the panel on the right, there are all these variables in NHIS where you can identify people's risk for diabetes through previous gestational diabetes, their weight, their age, several other factors. And you can then do exactly the same thing we did on the left panel on the right side. And of course, this is a bigger group of people. But again, very steep drop-offs, and incredibly steep when you think about these diabetes prevention referrals that really are just not happening nationally. So you could then take it into management of diabetes and do similar things. Here with the NHANES surveys again, over a 12-year period, we look to show what proportions of people with diabetes were achieving different metrics of care. And in this case, we looked at things like their A1C. And the beauty, again, of NHANES is that you don't just have to look at the proportion under an A1C of 7, for example. You can actually look at the distribution of everybody across A1C. And so here you've noticed that we did the distribution figures up at the top, and we then looked at this specific threshold, the A1C under 7, and showed how it changed from 1999, 2002, all the way to 2007 to 2010. And we did the same thing for blood pressure, and we did the same thing for cholesterol, and we did the same thing for tobacco or do not smoke, the so-called ABCD of diabetes care. These are data from what is called the National Ambulatory Medical Care Surveys. And these are data that Megha Shah and her team ran a few years ago. These are also publicly available. These actually go out to clinicians around the country. And I think it's a very healthy sample. It's about 30,000 clinicians that are surveyed every year. They're asked to identify the patients in the previous week, and it's something like 30 patients in the previous week. And they have to fill out a fairly detailed set of information about what was done during the visit. And so this includes things like, was a new medication started? Was an old medication refilled or discontinued? Were they given physical activity counseling in this case? And so Megha and her team did a fantastic job trying to look to see whether people with diabetes, as they were coming in and out of ambulatory medical care in the United States, were they receiving, for example, counseling regarding diabetes diets, any counseling whatsoever, diabetes exercises, etc. And you'll see a fairly gentle decline over time between 2005 and 2015, slightly disconcerting and worrying that people aren't getting counsel the way they should be. And the absolute numbers are just very, very small. Mega further took it into greater detail to try to understand, were there differences by race ethnicity? And it turns out not much. But she went further to look at geographic region, and it turns out compared to the west of the country and the Northeast, the rest of us are lagging a little bit. And she then looked to see whether it mattered by physician specialty. And there really wasn't very much difference, other than to say that potentially our specialist colleagues do a little bit less, although non-significant. But when she went down to the detail of saying, what about APPs? What about advanced practice providers who are physician assistants and nurse practitioners? And you'll notice that they are much more likely to provide counseling than physicians are, which I think is quite fascinating and speaks to where the gaps are in terms of where one could improve. If you're interested in medication use, for example, these are newish data from Michael Fang and Liz Selvin at Johns Hopkins, where they again use the National Health and Nutrition Examination surveys over a 20-year period in this case, to look at the various glucose-lowering medications in panel A and how their prevalence of use has changed over time. For those of you that are interested in the newer medications, that's the pink, the SGLT2 inhibitors and GLP-1s. And you can see it's really tiny and edging up. You'll see in the second panel in B, the blood pressure lowering medications. And then in C, statin use. In general, again, we only have about less than 2/3 of people with diabetes on a statin. And really the recommendation is that all of them should be. These are very interesting data currently under review by one of our own, Rodolfo Galindo, in endocrinology. Rodolfo used the MEPS surveys, which are fascinating data. They use the NHIS sample from the year before and essentially do a random subsample of those people and create panel data. In other words, a portion of them are then followed for 2 years. So you actually have within a really powerful nationally representative data set, you have 2-year follow-up for some people. And so what Rodolfo did here, which is fascinating with TEG's help, is he looked to see in people with diabetes who are also overweight or obese, and in other words, their BMI is 27 or higher, what proportion of them are using weight-inducing medications that are diabetes-specific, weight-reducing medications that are, again, diabetes-specific, and then weight-inducing that are non-diabetes, weight-reducing that are non-diabetes, and then weight-neutral diabetes medications like metformin. And you'll notice here that it's really a big proportion of people, over half, that are using a weight-inducing medication, which is kind of interesting, whether it's diabetes-specific or not. And then it's fascinating, what he was able to look at was how does that change in the following year? And you'll notice here that as the panel opens up, the green is the proportion that continued use of that medication in the next year. And the sort of reddish color is the proportion that didn't. And in particular, you'll notice the discontinuation was higher for weight-reducing medications than it was for weight-inducing medications. And so these are already people that are overweight or obese that could significantly benefit from weight-reducing medications. And this really shows you that our treatment paradigm nationally is flawed. We are giving people lots and lots of insulin, lots and lots of sulfonylureas from which they are gaining weight. And they're continuing those in the subsequent years, but really discontinuing the ones that should help them more. The MEPS data are also very useful for looking at costs and looking at the excess expenditures in people with diabetes. These are slightly older data now, but what's really nice about it is you can compare people with diabetes to people without diabetes and then estimate a difference. And our CDC colleagues ran this paper a few years ago, really identifying for you which cost buckets have tended to decline over time. And that's largely been sort of inpatient care, and which ones have grown over time. And that's largely been sort of outpatient care and diabetes medications, as you can see here on the bottom right of your screen. You can also use what are called the healthcare utilization project data with some sort of denominator is what you need for national estimates. And so you can either use the NHIS data or you can use the American Community Surveys data. These are well used here in a study by Ed Gregg and colleagues from the CDC, looking at incidence rates for various diabetes complications over time. And this very powerful paper was in the New England Journal a few years ago, showing you general declines for incidence of diabetes complications, and in particular, larger declines for sort of the macrovascular complications of diabetes, in other words, stroke and heart attacks, and sort of milder declines for things like end-stage renal disease. But you know, that what Ed did is sort of showing you the big picture of the United States. But if you think about it, the country is made of 50 states, and one could even consider these 50 very fragmented different states in terms of what is available. And so fairly recently, a couple of years ago, we actually purchased data using a grant from Merck & Company to purchase HCUP data for the blue states that are here. And we purchased the inpatient data, the emergency department data, and have really worked hard to really try to show if and how disparities exist both across states and within states, and what those disparities might be. So I'm going to show you a few slides from those just now. Here's the first one of these. This is using the National Emergency Database and the state emergency databases for all the data, for all the states you see at the bottom here that we have access to. And so just to orient you here, two critical lines for you to look at first. The black line is the national average that we generated so that you could see the cross-state variation. The dotted vertical line is showing you where there was a conversion between ICD-9 and ICD-10 coding, which did make a difference to a lot of estimates around the country. And these data now are under, they're now in print at JAMA Network Open, and congrats to Teg Upal for that work. So you'll see here for the non-Hispanic white population, you'll see the national average right here in the black line, and reasonable dispersion, but not a whole lot, and largely below the national average for non-Hispanic whites using the emergency department for diabetes-specific usage. This I should have clarified earlier. And you'll notice here, when you look at the other two, for the Hispanic group, a little bit more dispersion, but generally fairly low. It's really in non-Hispanic Black Americans that you see massive dispersion both across states and much higher rates of emergency department use, suggesting potentially that for diabetes-specific things, these are not being optimally treated in primary care, and or this group does not have as good access to high quality primary care on a regular basis, and may be using the emergency department for accessing some sort of care. Teg then did the same thing looking at insurance types, and you'll see here again, the black line is the national estimates. For private insurance, for those that are privately insured across these states, there are very low levels of emergency department use across all these states. But again, when you look at Medicare and Medicaid, massive dispersion, and always much higher than the national average for all these states. Same for Medicare, and somewhat dispersed around the average for those that are uninsured. Sarah Turbo used similar data sets, in this case, the inpatient data sets for the national and for these states. And she looked to see what was happening using the same metrics. Here, what she did is the black line is the national average again, and the blue line is the average of these various states for that race ethnic group. And of course, the gray lines are each of the different states in various dotted forms. So you'll see here again for non-Hispanic whites, a general flat or decline in the use of inpatient services for people with diabetes. And as you then expand that to Hispanic population, it probably stays roughly the same with a bit more dispersion. But for non-Hispanic Blacks, there's just a lot higher use of inpatient services, which has been declining over time, but also just a huge amount of dispersion across states all the way from Utah to Arizona and Kentucky, which were the highest. She did the same thing also, and you'll notice a very similar trend for private versus publicly insured or uninsured individuals. last couple of data slides, I promise. The other administrative databases are the Optum databases, which need to be purchased. These come from United Healthcare and a large number of people that they insure commercially. The data here were run by Rosalina McCoy and her team at Mayo. And what she was really showing here were essentially the rates of hypoglycemias in the population. And you'll notice here, the biggest thing was that the more you have comorbidities, the more likely people are to experience hypoglycemias. And certainly, in particular, she was able to identify which are the groups who are most likely to have hypoglycemias. And it's really those that have diabetes and a comorbidity like end-stage renal disease or dementia or heart attacks or heart failure. Here's more of Rosalina's work, this time looking at hyperglycemia. And in this case, initially looking at type 1 diabetics. Across the country, you'll notice the highest risk groups for having a hyperglycemic episode are those that are non-Hispanic Black, and again, the lowest income groups. And in type 2 diabetes, very similar. It's the young population, it's the non-Hispanic Black population, and it's again, those in the lowest income quintiles. She's also able to look, or she and other colleagues were able to look at the use of various medications using Optum. And in this case, they were able to stratify by different comorbidities, whether people were able to get SGLT2 inhibitors, which are particularly indicated for these populations. And in this database of almost 1 million people, she identified that people who are non-Hispanic Black are 17% less likely to be receiving these medications, even though they have the same insurance, which I think again speaks to, it's not just insurance and it's not just access. What are the structural and other barriers that one needs to address to really make a dent in these gaps? These are interesting data. The last data piece, I promise, which is using the US RDS data, which is the renal data surveillance system. And this is usually an amalgamation of many different data sources. These were recently published by CDC literally a month and a bit ago, showing you both the incidence of end-stage renal disease cases by year and showing you the incidence by cause. And you'll notice here quite a difference between end-stage renal disease that is due to hypertension and other causes, which is the lower arrow, the dotted one at the bottom, and those caused by diabetes, which literally have had about a 50% bump in the 20-year period that they were following. So this really, I think, is quite a segue into what Rachel will talk to you about, which is how to use implementation science methods to make a dent in addressing end-stage renal disease.
Great. Yes, I think, thanks so much, Mo. Databases, I think, can be really important to describe this gap that you're talking about and generate important hypotheses in diabetes. And that can really help us to identify the interventions that we might need to do. And that's an area of research that I've spent a lot of time on. So I want to just talk a little bit about implementation science and then provide an example in implementation science specifically around health equity. So, I think one of our core goals in this core of ours is to help generate policy and practice-oriented diabetes research that's equitable and sustainable. So we've heard, I think many of us have heard that oft-quoted citation that it takes 17 years to run only about 14% of original research to benefit patient care. And implementation science really focuses on the strategies to adapt and integrate real-world or evidence-based knowledge and interventions into the real world to have an impact on patients and populations. And I think this figure here, where's the gap? How do we scale our approach really in translational research begins with basic and other pre-intervention research at this lower left-hand side that can help inform the development of novel clinical or preventative interventions that are then tested in very controlled settings and efficacy studies that are under these ideal conditions. And then a highly trained team usually helps deliver that program, often to a very homogeneous group of patients in an efficacy trial to look at, where there's very high fidelity to the efficacy side, to look at that in efficacy trial. But that really only answers this, does this work under these rigorous scientific conditions? And so once we establish efficacy, moving into effectiveness studies and where the intervention, where we would want to test how this is embedded in our community or health system for delivery, is really critical in implementation science and bridging that gap into translating research and evidence-based practices into the real world. So I think that this focus on efficacy, moving from efficacy to effectiveness in our diabetes research and translational research is really critical to reach the population and sustain, and has a lot of applicability in terms of health equity research. You can go to the next slide, Mo. So this is a great cartoon here that I think really illustrates or maybe overemphasizes some of the points that we as researchers probably need to do a better job at addressing, not just the knowledge translation. I think too often we publish a paper, we stop with this publication and perhaps hope that people who read this publication, maybe the few people that read our publication, are impacted by reading maybe our discussion section that offers advice on how to change practice. But too often, maybe nothing happens. Maybe we're not doing enough here around the how do we do this. Maybe news media picks up on some of this research and a lot may be left in that translation to how we move from a knowledge gap to this, how do we implement effective practice in action? And so this is where I think implementation science really can be used to specifically target a lot of areas. And here there's some examples of the different areas, whether that's at multiple levels, the patient level, the clinician level, or the health system level. But the science of how do we best translate an evidence-based practice or intervention. There's really an application of a science in how to do this. It's not simply just publishing our papers and stopping there. You can go to the next slide. So I'm going to offer a very brief example in just 3 slides of something that took 5+ years to do. So this is a challenge, but an example here, we're moving a little bit. This is an example I'm familiar with, moving really kind of downstream a bit in end-stage kidney disease, where, as Mo just mentioned, diabetes is one of the most common causes of kidney failure, and looking at some outcomes for this patient population. But briefly, back in December 2014, the US implemented a new kidney allocation system change that was really around trying to improve equity and access to transplant. And our big gap here is that there's, you can go to the next bullet here, we know that there's racial inequities in access to kidney transplantation, and that's really the best treatment for someone who has kidney failure. And this policy, early results when it was implemented, suggested that racial disparities eliminated from waitlisting to transplant, but earlier steps prior to even just getting on the list. There was a knowledge translation. This policy happened, but earlier upstream, where patients are receiving care in dialysis facilities, and the practitioners and the clinicians that see those patients 3 times a week on dialysis really didn't know much about this policy change and how it could actually really impact their patient population. You can go to the next slide. So this was a hybrid type 1 effectiveness implementation study we did to really try to extend the reach of this kidney transplant allocation policy change. And very briefly, I'm just going to really focus on the process evaluation and the implementation part of this, but the intervention included, we randomized 655 dialysis facilities across the country who had low wait listing. About 56% of the patient population within those dialysis facilities had diabetes. And they were randomized to multi-level and multi-component interventions that targeted both the health system, the dialysis facility staff, and the patients, and included a number of quality improvement as well as educational interventions targeted to some of those staff. And one example here on the right is this audit and feedback report, which has a lot of evidence of efficacy in a number of settings, but basically a benchmarking report that showed the dialysis facility, here's how you're doing with respect to racial disparities and access to the waiting list for your patient population. And here you have a lot of patients who have been on dialysis for a long time. And because of this policy change that I won't go into all the details of, your patients could stand to benefit and go to the top of the list if they get on the waiting list because of the way that allocation time has changed in this policy. And so our intervention was really trying to extend the reach of this policy and moving further upstream in the care process to try to encourage not only waitlisting as a primary outcome, but also racial disparity reduction in waitlisting. And so you can go to the next slide. I'll talk a little bit about the process evaluation of this. So again, it was a hybrid type 1 effectiveness implementation study, meaning that our primary aim was the effectiveness of the intervention, but we also really wanted to gather data on the feasibility and sustainability of integrating this type of intervention that focused on education about transplant itself and this policy, which is still in place today, and how it could help patients and their patient population, and the clinicians to be able to communicate that to their patient population. And being able to understand, how this intervention, whether the intervention was implemented as intended. And so for this, we did a mixed methods design. And so we collected survey and interview data from intervention dialysis facilities. We did interviews with staff from intervention facilities. And for the purpose of the process evaluation, sort of identifying whether this was implemented as planned, we looked at stratifying the facilities into high implementers, that are those that used at least 3 of the 4 intervention components, low implementer facilities using at least 1 to 2 components, and non-implementers that didn't use any intervention components at all. And of course, our process evaluation was really guided by an adaptation of a well-known implementation science framework, the RE-AIM framework, which is illustrated here: reach, effectiveness, adoption, implementation, and maintenance. And last slide, I'll talk very briefly about some of the findings for that, just to put this into context of how this is helpful for us in terms of interventions moving forward and where to go with that. So we did we surveyed participants, as I mentioned, who were mostly facility administrators, nurse managers, and social workers, and targeted medical directors and nephrologists at the facility level, but ultimately very few ultimately participated. We had structured interviews amongst staff from both high and low implementer facilities. And so about half of the facilities implemented all, or 57% implemented all of the intervention, 31% were non-implementers. But this was helpful context for us to understand that there was a dose response effect. So there was higher fidelity associated with increased provider knowledge of these policy changes. And staff from high implementer facilities are more likely to rate effectiveness and usability of the intervention highly. So I won't go into all the other details, but hopefully that gives a little bit of context here, thanks Mo, about the how this was able to help us guide how we might take and do an intervention in the future, and communicate some of this to them and understand that dose response. And if we hadn't measured some of this context around here, we would not have been able to understand that. So I think, yeah, go ahead and we can go to the next slide, that for opportunities and that are design and evaluation for Equity Core can help hopefully combine some of this use of databases, but also help to move along to how do we take what we're understanding and doing in some of the data analysis and databases to also move towards implementation.
Cool, thanks. So just to share with all of you that our Georgia Center has had probably now 6 years of experience, in that we were funded between 2015 and 2020 and recently refunded for another 5 years. Sorry, 2016 to 21, and then refunded for another 5 years. And in this new rendition, we actually have more partners. We have partners from Florida and Tennessee, who you see noted here. And specifically that's to focus and support interventions and implementation science that is focused on technology and the use of technologies to improve diabetes health equity, both in prevention, management, you name it. And so just to share with you some part of the original idea around having a center like this is that many of us for years at Emory were working on various components of diabetes in total silos. And the beauty of this center is that over time, it's really started to connect the various groups at Emory to work together. And so increasingly, as you see here in this network diagram on the right, a lot more publications in the last few years have been generated across the groups, and that include people across the School of Medicine, our partners at Morehouse, Georgia Tech, and nursing. So in addition to bridging the silos, our program over the first few years, first 5-year period, funded about 17 pilot grants, as well as 5 micro grants. We had something like 70 seminars. One of these is a good example of that. We leveraged a lot of center and institutional resources to recruit, and we recruited in the order of 31 new faculty who were very successful. Many of them came in and won K awards. And we have a number of our faculty who are engaged in real life translation. Guillermo Ampires being a prime example. For example, he chairs the Emory Healthcare Diabetes Council. Mary Beth Weber participates in the Emory DPP program for diabetes prevention. And I believe Rosette Chakalakal is also going to be joining that group soon. So in terms of the broader center, if the slide ever comes to fruition, there are multiple cores. The core we are talking about here is the one on the bottom left, called the Design and Evaluation for Equity core. And just to, in 5 minutes, share with you some of our opportunities that we hope you will engage with. Rachel and I, our focus and the core's focus really is to work and support both junior and underrepresented minority investigators and promote equity through a variety of opportunities. One is to try to provide more access, or at least to facilitate more access to these various data. Not all of them, as I said, are freely available, but a number are. And so we're in the later stages now of finishing our compendium of data sources, which we are trying to figure out how to put that up on our website and to make it user-friendly so that you can filter by whether it's free or not, by the various specialties that you're interested in, and to really help you drive a lot more scholarship from this work. We also would like to provide expertise regarding study designs, analytical methods, and certainly Rachel and I are available to all of you, specifically for the implementation science methods. And you'll see in the next couple of slides some of our experts in the core who will provide specific expertise around data use also. And then lastly, we're really interested in supporting dissemination of this work and engaging all of you. So if any of you have new ideas, just want to come and talk and want to grow something within the core, our ears are open, our emails are always open. We may take a minute to respond, but we will get back to you. So just to share, these are some of our experts, specifically those with epidemiology experience and expertise. We have Mike Goodman and Jess Harding. Both of them have tremendous expertise. They're both delightful people to work with. And you can see their various areas of expertise here listed under each. In terms of health analytics, we've got 2 amazing faculty from Georgia Tech. We have Nicoletta Serban, who also co-leads the technology core, as well as Turgay Iyer. Both have tremendous expertise in health analytics, use of all these data sets, and newer methodological expertise in terms of machine learning and thinking about statistical inferences using these newer methods. And last but not least, Steve Culler brings enormous costing and health economics expertise, and has done work in all of the areas listed you see here, has used all of these data sets and, for example, co-mentors with me. And I've always found Steve is just terrifically responsive, very helpful, and will really elevate the work that you want to do. So what we're hoping you take away from all of this is that there are huge gaps. The databases that are available both publicly and privately can really do a tremendous job in helping you identify what said gaps are. And our core is really happy to facilitate access to these, to really help you understand where are the health equity gaps, and then to work towards really closing said health equity gaps. I think that would be really amazing, and we'd love to engage all of you. So we'll stop there and take any questions. I think we have at least 10 minutes for any questions you have. Don't feel shy. Hi, Francisco.
Hey, thanks Rachel and Mo. Great lecture and great data. It's really nice to see all the experience you guys have gained over over time to use all these databases to answer those questions. My specific question will be more for the logistics on how can we use the resources from the core. So how does it help people that are here and they want to investigate a question? How do they approach you? How do we make this happen? Do we want them to send, hey, I have a question, I have my specific games and I want to answer this, how do I do it? Can you help me with the design? How do you visualize that?
Yeah, that's a great question. I'll happily start, and then Rachel can correct me or suggest alternatives. I think initially we probably will do everything very piecemeal, which means, come through emailing us, come through emailing Jeff Mills at the center, and we will try to link you up with the right person, because we personally won't always know each of these data, but potentially some of our experts or broader networks might. As we get further along, really the goal is to have this on the website where it's freely available to people, to not have the extra step of having to go through us. Realistically, as I said, not all of these databases are going to be freely available. And so what we're trying to do is trying to filter on that, but also trying to help people identify who is a good point of contact. For example, with HCUP, all it requires is that you get access to the data from one of the people who's bought it, and then you have to do some AHRQ requirements in terms of IRB training, which I think is a couple of hours worth of work. So hopefully we're working towards that, where it becomes very natural for people to use them broadly and then to engage with us for expertise. But that's my thinking on it. Rach, do you want to add anything?
Yeah, I mean, I completely agree. I think you said it really well, and I don't think I have too much to add, just that, yeah, happy if people aren't sure where to go, to send us an email, and we can go from there. We may not know all the answers, but we can help to be serving as connectors as best as we can.
Thanks for the question.
Other questions, comments?
So while we're waiting for people to come up with questions, the other thing I did want to mention was that, we've used national and state data very much to illustrate gaps, using data in a very descriptive fashion. I will say that there is increasingly, over the past 5 to 10 years, a lot more use of data for local population health initiatives. For example, Emory Healthcare, Grady Health, other health systems around the country actively run some of these data on a month-to-month, week-to-week basis to try to actually improve how things are going. And the example that you saw in the case that Rachel presented, the ASCENT study, again, there, it's sort of this idea of using data on a regular basis, almost as an audit and feedback, almost as a gentle behavioral nudge to try to get clinics and systems to operate better. So certainly don't think that it's only descriptive data that you can use here. You can certainly use local and other data for improving care.
I had another question about logistics.
Yes.
So if you I know the center is also funding pilot studies that can use these databases and to answer those questions. And you may not have preliminary data, or you may be moving to the diabetes world, and sometimes there's junior faculty who wants to get started, wants to do research. And can you help us understand a little bit about the timeline in terms of how can you use those resources? Let's say the grant is for 30K, but more like the logistics for people here that may want to write a grant. So like, how do you visualize that in terms of what can you complete in a year to be realistic? If you wanted to answer a question on disparities in, I don't know, diabetes and kidney disease or something like that.
Yeah, that's a tremendous question. It always depends on, how quickly you can get access to the data and how well thought out your analyses are. Because I think in general, with most of us, you'll know, having done these before, halfway through the process, you realize something that might change the analysis quite substantially, and then delays the whole progress through to sort of a submittable product. So I think those two are the big defining factors. I think it's very possible within a year personally, but I'll just open up and say, Rach, do you want to add something?
Yeah, I mean, just say I think that having the pilot grant funding and combining with the database access is really a great way to show when you're submitting then extramural funding later, just that, you know, even if you don't have a final product from that, which is harder to do in a year, demonstrating that you've worked with other partners, maybe you have some abstracts in the works, and that you have the feasibility of you have obtained that data set or that data that you expect that maybe you would use for a future grant is just really valuable. So, but you know, I think in a year, an ideal goal would be to get access to the data and have at least a publication drafted, and that helps you figure out the co-investigator teams and some of the feasibility aspects that are just really critical when reviewers look at your funding for extramural grants. Yeah, I mean, one of the things I get, if there's no other questions, is one of the questions I think that other people tend to come with me in terms of implementation science, and maybe I'll ask this to you, it's just, you know, it's hard because implementation science is often when you have some evidence-based practice or an intervention that has already worked. And I think a lot of more junior investigators feel very daunted by, you know, especially if they're just starting out, how do they get to this point where they're doing implementation science when, you know, they still think that an intervention needs to be developed? It's this long pathway. Can you talk about just other ways that, you know, it's not always just developing your own intervention? I think you gave one of those examples was you can use existing data like we did in our ASCENT study as one, where you use surveillance data to do that. But do you have other ideas of how to get engaged in ways that you've seen maybe junior investigators do that in implementation science?
Yeah. Great question. So, I mean, I think, you know, we do tend to rely on the idea that something has to be a proven intervention and that there's a gap in how it's being utilized or adopted, et cetera, nationally or at a local level. And that in some way, identifying what is the way that you will improve it, what is the implementation strategy that you're using, really is important. What you want to avoid, this is a slight preamble to answering your actual question, is that what you want to avoid is this idea that you've already predetermined what your implementation strategy is, and you're going around the world with a strategy that you want to implement somewhere. What you really want to try and do, and this is actually a huge credit to Carla Galavitz, who used to be at Emory and work with our crew at the Global Diabetes Group, was she always used to use this phrase, don't go around the world with a hammer trying to look for a nail. Find the nail, ask the nail what it needs, and then pick your hammer. And so I think there's a huge spectrum of work that needs to be done there that is formative, that could be done, for example. I think there's all these data analyses. And then frankly, my true answer to your question is, if there isn't a proven intervention yet, I think the burden of proof is for you to then develop. And I would say, don't be scared of efficacy studies. They don't have to be, you don't have to go straight to the final scalable policy that you want to evaluate. I get that it's cooler or cool in general, but it's also really cool to come up with a new intervention entirely.
Right. And then even at the start, I would say you can, even if you're doing efficacy studies, you can be doing that with implementation in mind and setting it up. So it's a longer pathway, but yeah, that's great. Great answer. Any other questions?
Let's just check the chat real quick before we give up on everything. Mark has mentioned, if anyone isn't yet a member and you'd like to become a member, please don't be shy. There's a link in the chat. Any other final questions?
Hi, Mo and Rachel. This is Elizabeth. Thanks so much for a fantastic presentation. I'm really excited to hear about this core. I was curious if you could speak a little more to the providing expertise around study designs and analytic methods and how you envision that looking. So would it be that we might have a one-off consultation with some of the folks that you noted, or would it be something a little bit more involved? For example, someone joining us and being a co-author in a paper, for example.
Could be both. It could be whichever you are comfortable with. Rach?
Yeah, I mean, I think we hope that this, it could be a minimum of just some advice and you seek out some input on one component, but I think we hope that there are some longer term collaborations and relationships that are formed too. And that may be mutually beneficial to both.
Great, thanks.
And I will say, Elizabeth, we don't have experts that do sort of analyses of like stepped wedge designs or those sort of things yet. But I really think that, using the center and getting ideas from you and others whom we might recruit may be other avenues that we think about investing resources in.
Excellent, thanks.
Great. Well, thanks everyone.
Yeah, thank you all for joining. And hopefully the recording and/or slides will be available to you through Jeff. Thanks for joining.
Great, thanks for joining.